Hello, this is Ed Kim. I'm the site director at the VA, and I am here with Dr. Warren Gasper, one of the vascular surgeons, and we're gonna.
I'm one of the vascular surgeons at the VA, and we're going to talk about how to evaluate and present a consult.
So I think these are the basic steps of doing a consult, and one of the main focuses, the focal point or take-home message is that seeing the actual patient encounter is the fourth step. There's a lot more things you need to do than just go see a consult if you are called for a consult. So the steps are: you need to identify the reason for the consult. You need to do some background reading, gathering information from the electronic medical records to get further information, and then you go see the consult. And then you can come up with an assessment and plan afterwards, again referring to the references. And we'll also talk a little bit about tailoring the presentation to the context of the situation.
Right. And I just think it is important that you make sure that there is a question that you're trying to answer for the consulting service. So make sure that that's clear in your mind before you even go see the patient. And a lot of times you'll be called for consults that seem urgent, and they very rarely are they going to be actually truly emergencies. At the same time, that this needs to be an efficient process. You need to be able to start with the consult, do some pre-reading, see the patient, think of a diagnosis, and have all this done within about 30 to 45 minutes to make this an efficient process for whatever the next steps might be.
Yeah, I don't think we want you to be rushed, but I do think that it's important to keep a mental clock going. And that's the reality of clinical practice for all of us.
So just to start off with the reason for the consult, I think it's important to know the context in terms of, is it the emergency room or inpatient service or another subspecialty or an outpatient practitioner. But even though this is going to be a consult on a surgical service, we're not technicians. We're not here to just sort of fulfill a work order. This is actually an evaluation, and that's what's important, is that we as the interventional services are not just providing a service, but we're also doing an evaluation and putting in our 2 cents about how we think this patient should be treated. And we also may be asked to help manage things, which could include narrowing a diagnosis and offering treatment plans, and in which case that's kind of more of a sort of a collegial consultation.
So I think the first step is, and this is oftentimes underappreciated, is pre-reading, or background reading, which really I think you should spend at least 5 to 10 minutes to browse through a reliable and a concise reference. I don't know, how do you feel about UpToDate? I've always found UpToDate to be a little bit of hit and miss.
I agree. I think it can, especially for sort of surgical problems, sometimes focus a little too much on the broader sort of medical issues as opposed to a focused sort of surgical review.
Yeah.
But I think that since it's available, and easy to get to on the computer, it's often a good place to start.
Yeah. But I also think maybe a short textbook or asking your resident to where you can go for that is also a good way to try to avoid getting on a bad reference, which can waste a lot of time. And I think the details that you want to focus on is like what is the classical presentation? What do you usually find on the history and exam? So you can kind of figure out what you want to ask or what parts of the history or details that you want to make sure you cover. And then what labs and studies are used in diagnosis, so you know which ones have been done or haven't been done. And then lastly, just kind of the natural history of disease process as a whole, pathophysiology.
And the point here is not to sort of bias yourself so that the whatever the consultant is asking you to diagnose, that you just automatically go in and agree. But the idea is that you want to see, are there any things here about the presentation of this particular patient that are, very different or not consistent with how this disease or process typically presents. And so you want to, that's why, I think I agree, it's very important to just have this idea of how this should look, and if it doesn't look exactly that same way, what might be the explanation for that?
Yeah, I think a lot of times we get consulted for with somebody already with kind of a diagnosis or later in their evaluation uh, process. So gathering information on the specific patient, right? The electronic medical records is usually what we use.
And I think that it's important to take a look at the studies yourself. So make sure that if they're reporting labs to you, that you look and you make sure that those labs are current labs or recent labs that have happened within the past day or few hours. You also want to take a look at the medical history, the surgical history, with an idea that you're looking at it from a surgical perspective. So, have they had any previous operations? Have they had the particular operation that they're asking you to perform already?
Yeah, it's a full H&P.
It's a
Yeah.
full H&P,
Yeah.
but with a kind of a surgical bent. And you also want to go over the imaging yourself, and this is an opportunity for you to sit down with the residents or even go down to radiology and take a look at the imaging and make sure that you understand what it is that's
Yeah.
being seen on these films.
Yeah, I think one of the big pitfalls is a confirmation bias where, especially novices like hang on to the words or sentences in a note, probably a pretty well written note, and they put too much weight on it rather than trying to make an independent evaluation of the data. So finally, you're seeing the patient. After all that.
Seems like this already took hours, but but basically you want to be prepared. I mean, the point of doing the pre-reading and looking in the medical record is to be sort of ready with a list of things that you want to further clarify or figure out. You want to let the patient tell the story in their words, and this sometimes is challenging, but you want to have them tell you about exactly the symptoms they're having, how things have developed, so that you can make sure that this fits with the pattern that you are expecting to hear. But at
Illness script.
right, but at the same time, you don't want to spend a lot of wasted time with the past medical history or medicines that's real or things that are not pertinent. And so, it's important to ask these open-ended questions, but at the same time, you don't want to open the floodgates for the time that their aunt got sick and et cetera, et cetera. You want to really focus this on let's go over this list of your medical problems and your medications and
Yeah, I think there's a tendency to get too far ahead, too much into that, because that's oftentimes what people are comfortable with. But just to confirm, but don't explore.
Right. And then on the exam, again, you want to focus on the area of interest and make sure that you are doing a complete exam and again, this is where this pre-reading helps really direct what you are going to focus on.
Great. So for the assessment plan, you review all the data, compare it, like you said. I think you've really emphasized this, Dr. Gasper, the idea of a typical presentation, the illness script, whether it actually fits or not, because that actually helps us decide how clear the diagnosis. Sometimes the diagnosis is pretty nailed because it's a CT diagnosis or a biopsy type of diagnosis. And then you focus on the treatment options or further evaluation depending on where they are in the evaluation process. And this is also another time to go back and read a little bit more, right?
Right.
So when you're going to see the patient, you don't necessarily have to read about all the different types of treatment, but after you've seen the patient, as you're about to kind of put it all together, I think then you can give yourself a few minutes to say, hey, this is what I think the patient has, and these are the treatment options. Which ones seem to make most sense?
Yeah, exactly. I think, and I think the other thing that goes along with this too is just, a little thought about what kind of operative candidate this person is in terms of, this is, a surgical evaluation.
So finally, there's the presentation, and it really depends on who, when, and where. And I think you definitely need to have a one-liner ready, and then probably an abbreviated form. I think most people won't ask for a full presentation because it's such a busy day, especially if it's in the middle of the day, your residents are in the OR or they're in clinic in between cases. So this is where I think it's been mentioned in the podcast for the oral presentation and how you have to basically decide what to include as the key details. And this is where you go from the reporter to the interpreter. You have to interpret and prioritize what's the correct data in terms of the importance and relevance to the question that you're trying to answer.
And I think that this is also where it, to just to build on that in terms of being the interpreter, it's common for us to get consults for one condition, and then we go and evaluate a patient and decide that it actually is a different condition. And and I think this is where you have the opportunity to say, well, they consulted us for A, but really, when I went and talked to the patient and read about this, I think it's actually B. And that's not an uncommon thing for us to encounter.
Okay, great. So I'd like to conclude by thanking Dr. Warren Gasper for joining me in this podcast. And I also, I think we both would like to emphasize the fact that consults is a great opportunity for learning.
Yeah, thanks, Ed. This has been a pleasure, and I think there's much to learn from these consults, and you really should enjoy the chance.